Our ninth lecture in the series will be on thrombosis and antithrombotic drugs. By the end of the lecture, you should be able to describe the process and regulation of hemostasis, including the proteins and cell types involved in clot formation and coagulation cascade. You should be able to describe how thrombosis may arise and the potential pharmacological targets for therapy. You should also be able to compare and contrast the different types of antiplatelet drugs, including their mechanisms of action, pharmacokinetics, and side effects. First of all, I'd like to define a few terms. Hemostasis, firstly, is the stopping of blood loss in damaged vessels, which involves vasoconstriction, adhesion, and activation of platelets at the site of injury, and the formation of insoluble fibrin strands. This is shown in the diagram on the right. Thrombosis, on the other hand, is a pathological state involving the formation of a hemostatic plug that is activated in the vasculature in the absence of any bleeding. This occurs when there is endothelial injury, atheromatous plaque ruptures, when there is abnormal blood flow, for example during atrial fibrillation, or when there is abnormal coagulability of blood. Increased coagulability can occur in a pregnancy. It can occur with the use of oral contraceptives, or it can be inherited in conditions like thrombophilia. Arterial and venous thrombi have distinct structures, and we'll take a look at that in the next slide. This is partly due to differences in blood vessel structures. Shown here in the diagram, we have a picture of an artery, a vein, and a capillary. The most notable differences lie in the thickness of the vessels, particularly in arteries, which are more elastic, and the presence of valves in veins. Capillaries, on the other hand, are very thin in comparison and don't have valves or thick elastic present in them. These differences will affect how hemostasis proceeds and the formation of thrombi. This diagram summarizes the major components of hemostasis. This shows a vascular injury and the initiation of primary hemostasis, firstly, which involves vasoconstriction, the activation of platelets, and the formation of a platelet plug. Secondary hemostasis involves the activation of the coagulation cascade and the formation of a fibrin mesh and a blood clot. It then finishes with the degradation of the clot through fibrinolysis. We will now discuss these components in more detail. The formation of a localized blood clot to prevent blood loss and allowing healing occurs in 4 temporarily overlapping stages shown in the diagram on the right. First of all, there is localized vasoconstriction to limit the amount of blood loss. This is in response to a neurogenic reflex or local endothelin secretion, which we encountered in previous lectures. Primary hemostasis is where platelets are activated and then adhere to the subendothelial matrix at the site of injury, following the forming a primary hemostatic plug. The coagulation cascade then, which occurs in secondary hemostasis, occurs when the activated endothelium expresses a pro-coagulant factor called tissue factor. This complexes with factor 7 to initiate the coagulation cascade to activate thrombin. Thrombin then converts soluble fibrinogen to insoluble fibrin polymer, and this is what we see when it forms a matrix of the clot, which is the secondary hemostatic plug, which is quite stable. Antithrombotic factors then restrict the plug to the site of injury so that it can't form clots elsewhere in the blood vessel. Platelets or thrombocytes are cell fragments that arise from budding megakaryocytes in the bone marrow. The diagram on the top right shows a diagram of a platelet and its constituents. It contains granules in the cytoplasm, it has no nucleus, and it has surface glycoproteins. Platelet transformation involves adhesion, granule release, and aggregation. Adhesion is where the platelets adhere via secreted von Willebrand factor, adhering to glycoprotein 1b on platelets shown in the diagram on the bottom right. Glycoprotein 6 on platelets interacts directly with collagen in the vessel wall. Activation then involves agonist binding to cell surface receptors, leading to activation of platelet membrane phospholipase A2, leading to thromboxane release. Thromboxane stimulates granules to be released, and large amounts of ADP, calcium, ATP, serotonin, von Willebrand factor, and platelet factor 4. Aggregation then finally is when fibrinogen cross-links platelets by binding the GP2B and 3A receptors on platelet membranes, allowing them all to attach together. The goal of secondary hemostasis, or the coagulation cascade, is to form a stable fibrin clot at the site of injury, an example of which is shown in the picture on the right. This involves a sequence of enzymatic reactions using inactive proenzymes that are made in the liver that then get cleaved and activated by factors preceding them in the cascade. These are catalytic reactions and not stoichiometric reactions, meaning that one unit of activated factor can potentially generate multiple, up to 20 or 30 units of its product, rather than having a 1-to-1 ratio. This allows generation of large amounts of fibrin quite quickly. Reactions occur at the site where a phospholipid-based protein-to-protein complex has formed, consisting of a membrane surface, usually on activated platelets or on endothelial cells, an enzyme, usually one of the activated factors, a substrate, which is the proenzyme, and then a cofactor, quite often calcium. These are divided then into intrinsic and extrinsic pathways that depend on the stimulus, and they converge then at the activation of factor 10. It is called the intrinsic pathway because all of the components are present in the blood and is initiated by factor 12. The extrinsic pathway is so called because some of the components come from outside the blood, and it is initiated by tissue factor. Factor 10A, which is the activated version of factor 10, cleaves prothrombin, otherwise known as factor 2, to thrombin, which is known as factor 2A, as shown in the diagram on the top right. This then is able to convert soluble fibrinogen to insoluble fibrin, which forms long, insoluble polymer fibers. Thrombin activates factor 13 to factor 13A, which cross-links these polymers then into a highly stable meshwork or clot. Thrombin also activates platelets, causing granule release and platelet aggregation. Thrombin binds to thrombin receptors, which are known as protease-activated receptors, which require cleavage by thrombin of the extracellular N-terminal domain that acts as a tethered agonist. This is shown in the diagram on the bottom right. Binding of receptors on intact endothelial cells stimulates release of platelet inhibitors to limit the action to the injured site. These include molecules such as prostacyclin, nitric oxide, tissue plasminogen activator, and plasminogen activator inhibitor 1. This slide shows the main proteins involved in the coagulation cascade in both the intrinsic and the extrinsic pathway. As we've said already, the intrinsic pathway is initiated by factor 12, which then activates factor 11 and then factor 8. On the other side, we have the extrinsic pathway, and this is initiated by tissue factor, which activates factor 7A. Both of these pathways then converge on factor 10A via a series of calcium-mediated enzymatic reactions. This ultimately leads to the activation of thrombin and the formation of fibrin. Platelet activation, as we've said already, should only occur at the site of damage, upon tissue factor expression and upon phospholipid exposure, either on the surface of a platelet or the surface of an endothelial cell. The size of these hemostatic plugs should also be restricted and shouldn't become too large that would occlude a blood vessel. The activated endothelium releases procoagulant factors near the site of the injury to promote hemostasis, and the anticoagulant factors that restrict the propagation of the clot beyond the site of injury. These are shown on the diagram on the right of the slide. Procoagulant factors like tissue factor and phosphatidylserine tend to be membrane bound and localized to the site of injury, whereas anticoagulant factors are generally secreted by the endothelium and are soluble in blood. This essentially prevents the spread of the clot further down the blood vessel. Prostacyclin, or PGI2, increases cyclic AMP levels within the platelets, and it inhibits platelet aggregation and granule release. Antithrombin inactivates thrombin, as the name might suggest, as well as other factors including factor 9A, factor 10A, factor 11A, and factor 12A. And it is enhanced by heparin-like molecule that is expressed at the surface of endothelial cells. Protein C and protein S inactivate factors 5A and factor 8A in a vitamin K dependent manner, slowing the coagulation cascade. And both of these points are important because, as you'll see in the next lecture, they are major targets for anticoagulant drugs. Thrombomodulin is a receptor for thrombin and for protein C in the blood, binding thrombin, which allows thrombin then to cleave protein C to active protein C, which is able to cleave factors 5A and factor 8A. Tissue factor pathway inhibitor, or TFPI, binds to factor 10A and neutralizes its activity. The resulting complex interacts with factor 7A and TF complex, the tissue factor complex, forming what is called a quaternary complex, which consists of 4 proteins, shown in the diagram on the top right. Plasmin is generated by the cleavage of plasminogen by tissue plasminogen activator, or TPA. This gets secreted by the endothelium and exerts an anticoagulant effect by cleaving the fibrin into degradation products, as shown in the diagram on the bottom right. This will become important in the next lecture when we come to talk about fibrinolytics. TPA, or tissue plasminogen activator, is most effective when bound to fibrin meshwork. Its activity can be inhibited by the plasminogen activator inhibitor, or PAI. Plasmin itself can be neutralized in the circulation by alpha-2 antiplasmin to prevent the random degradation of plasma fibrinogen. So, having spoken about hemostasis, we'll turn our attention now to thrombosis. So, thrombosis is the pathological extension of hemostasis, where hemostatic reactions are inappropriately regulated, where clots become enlarged and where you get occlusion of blood vessels. An example is shown in the diagram on the top right. Thrombotic disease is common and has severe consequences, including myocardial infarction or heart attack, stroke, deep vein thrombosis, and pulmonary embolism. An example of an occluded coronary artery is shown in the diagram on the bottom right. There are 3 major factors which predispose people to thrombus formation, known as Virchow's triad. These are endothelial injury, abnormal blood flow, and hypercoagulability. Endothelial injury can occur due to shear stress because of high blood pressure or hypertension, because of hyperlipidemia, which we've encountered already in a previous lecture, because of diabetes due to increased glucose levels, because of injury or damage to the blood vessel, or because of infection. Abnormal blood flow can lead to turbulence or stasis rather than the usual laminar flow, and plaques and blood vessel bifurcation or arrhythmias are primary causes. Hypercoagulability, finally, is where you have abnormally heightened coagulation response, and this can be genetic due to a primary reason, because of factor 5 genetic differences, or it could be secondary or drug-induced causes. Particularly needs to be carefully monitored in the case of using heparin or in the case of using contraceptive pills. The diagram on this slide shows the possible pharmacological targets in both the platelet and coagulation cascades. The drugs in each case are listed in yellow and their targets in green for the platelet cascade, while on the right the drugs are shown in light blue and the targets are in dark blue. We will discuss the drugs targeting the platelet cascade first in this lecture, and then discuss the drugs targeting the coagulation cascade in the next lecture. The main drug classes used to target platelets are those that target prostaglandin synthesis, such as COX inhibitors, those that target phosphatoesterases, such as PDE inhibitors, those that target ADP receptors, such as the P2Y12 inhibitors, and finally, those that target platelet membrane glycoproteins, such as the GPIIb-Illa antagonists. These are illustrated in both diagrams on the slide, which shows both the activation and the binding of platelets together. Firstly, the cyclooxygenase or COX inhibitors irreversibly inhibit the synthesis of prostaglandins by COX-1, preventing granule release. Platelet activation induces phospholipase PLA2 to release arachidonic acid, which is then converted to prostaglandins or thromboxanes, and in particular, thromboxane TXA2 causes localized vasoconstriction, platelet aggregation, and granule release. This is shown in the diagram on the right. Platelets, it must be remembered, contains no DNA or RNA, so aspirin, for example, can permanently inactivate most available COX-1 on platelets up to 95%. Examples from this class include aspirin. Other NSAIDs or non-steroidal anti-inflammatory drugs are not used, as inhibition is not permanent. Shown in the diagram on the right is where aspirin binds to platelet cyclooxygenase. Clinically, these drugs are used in the treatment of acute myocardial infarction for the prevention of heart attack or myocardial infarction. Following coronary bypass or insertion of stents in patients with atrial fibrillation, in transient cerebral ischemic attacks or TIAs. These are like the mini strokes that you may hear about. These are taken orally in low doses, usually about 75 milligram, as opposed to the anti-inflammatory dose that you may take for a headache or for pain. They're rapidly absorbed from the ileum, and they are hydrolyzed by esters in the liver to salicylate, some of which is oxidized, some of which is glucuronidated or sulfated. They tend to be excreted in the kidney. The side effects include gastrointestinal bleeding at higher doses, as if you remember, prostaglandins can provide mucosal protection usually by the secretion of mucus and the inhibition of acid secretion. It can also cause Ray's syndrome in children, which is a form of hepatic encephalopathy, and salicylism at very high doses, where you can also get tinnitus, vertigo, hearing loss, nausea, and vomiting. Phosphodiesterase inhibitors inhibit platelet phosphodiesterases, preventing the degradation of cyclic AMP to ANP. Increases in cyclic AMP lead to a decrease in platelet aggregability, although the mechanism of action is not well known, as is highlighted in the diagram on the top right. Examples include dipyridamole, and is shown on the bottom right. Clinically, these are used in combination with aspirin for the prevention of TIAs, which are the transient cerebral ischemic attacks, prevention or at risk individuals who are at risk of myocardial infarction. They are also used in the prevention of thrombosis in stent or prosthetic heart valve patients. Side effects can include dizziness, headache, and gastrointestinal disturbances. Exacerbation of angina can occur in some patients also. ADP receptor inhibitors inactivate the P2Y12 receptors at ADP binding sites on platelets. This is coupled to the inhibition of adenyl cyclase, causing an increase in levels of cyclic AMP. These inhibit ADP-induced platelet aggregation, as is shown in the diagram in the top right. They usually require 8 to 11 days for maximum inhibition, and examples in this class include ticlopidine, clopidogrel, prasugrel, ticagrelor, and cangrelor. Clopidogrel and prasugrel are irreversible inhibitors, while ticagrelor and cangrelor are reversible. Clinically, these are used for ischemic stroke and myocardial infarction secondary prevention, and they can be used with aspirin in stent thrombosis patients, or instead of aspirin in those that are intolerant to it. This is shown in the diagram on the bottom right. These drugs are orally available with a half-life of 6 to 12 hours. The clopidogrel and prasugrel are prodrugs and have to be metabolized first of all by cytochrome P452C19 to an active metabolite. This is illustrated in the diagram on the right. Side effects include an increased risk of hemorrhage. Ticlopidine, for example, is associated with neutropenia, which is a big reduction in neutrophils, and also thrombocytopenia, which is a reduction in platelets. So blood counts have to be taken for patients taking these drugs. Clopidogrel can cause dyspepsia, rash, and diarrhea, and it's also contraindicated with omeprazole, which is a proton pump inhibitor, due to a cytochrome P452C19 interaction where it can influence the levels of omeprazole. The GP2B3A antagonists bind the glycoprotein G2B3A on platelets and prevent it binding to fibrinogen, and that bridges the platelets to one another, as is shown on the diagram on the right. Stimuli such as thromboxane, ADP, adrenaline, and thrombin induce the expression of GP2B3A during activation. Examples in this class include eptifibatide, which is a synthetic cyclic peptide. Abciximab is a chimeric antibody, and its mechanism is shown on the diagram in the bottom right, where it can, as shown in the antibody, interacting with the binding of the GP2B3A complex. And finally, tyrofibin is a non-peptide tyrosine analog. Clinically, these are used to reduce ischemic events in patients undergoing coronary interventions such as angioplasty, as well as in acute coronary syndromes such as myocardial infarction. These are often given as an adjunct therapy to aspirin or heparin. So the GP2B3A antagonists are given intravenously quite often, as can be seen in the diagram on the right. The abciximab binding is irreversible, with a dissociation time of about 24 hours, and its effects can only be reversed by infusion of fresh platelets. Side effects can include an increased risk of bleeding because you're preventing platelets from being activated. For abciximab specifically, it has issues with immunogenicity in some patients. It's also contraindicated for those with hypertension. So this is a very active area of drug development in the last decade in particular, and this slide gives you an idea of the number of new compounds and targets that are recently or are currently in development.